So then, of course, any examination you have, just examine from the hands of the whether it is stiff or anything, discomfort, anything. So then ask the permissions, ask from the first time. So for CBS, you just look for the clubbing. It's just make sound that you look at the knee back angle, like that. So look at the pedals, any sinuses, right? So, and then you go for the pass examination. The pass, usually you feel for the 15 seconds, multiply by 4. If it is regular, nothing, right? So if it is irregular, you have to test the whole 1 minute. So usually just for 15 seconds, multiply by 4, then you check for medial, right? And then medial femoral, usually we hardly do that. We ask the student to skip one. And then you do a collapsing pass. Collapsing pass is done, you must know the principle of doing collapsing pass. So you have to collapse the pass first so that you press it. So you don't use your tip of the finger, the palm of the finger you use, or the whole shaft of the finger you use that. You all across your radial artery that you press it until you don't feel it. So then you raise the hand up and then you release a bit, then you see the pulse was enhanced. Right? So if you feel with the tip, then you will feel the pulse of your hand. It's not the patient pulse. So if you do yourself, you will see, you press it until you don't feel it. Don't feel your pulse. Then you raise your hand up and then you release a bit, then the pulse will bound into your hand. So this is how to enhance. This is called water hammer effect. So if you get the pulse, the collapsing pulse is there, so that you will feel that pulse hit and go back very, very fast, not like the regular pulse, very forceful kind of thing. You will hit and go like that. So it will become more enhanced. Right. So this is just a way to accentuate the collapsing pulse. Some people, if they are experienced people, they feel the pulse, they already know this is a collapsing pulse. Right. So they just enhance it to see whether it's really collapsing or not. So you must know that some people just do like that. So they hold the pulse like the whole of the finger so that they squeeze it until you don't feel it. Release it. But some people do like that. So this is a little bit better. Pressing also a little bit. For me, this is good. So again, you can support the elbow. Okay. Before you do that, you have to ask the patient whether it's a sugar thing or not. Because some older patients, they have osteoarthritis and you can't do that. Right? So this is about that, and you go to the face. So face, so you check for parallel jaundice, look up and look down kind of thing, and check for open the mouth for central sinuses, you all know that. So then to the neck, check the GVP. So when you check the JVP, you look at this sternocleidomastoid muscle two head. Between that and then the ear, the styloid fossa, this line, you have to look at this line. Okay? This line. So if you can't see like that, you can see like that. Not too much. Okay. So you cannot taut the muscle also. The muscle you can taut, you can stretch, you cannot see the GVP anymore. So you have a little bit of relax but turn into that side. So if this line, you have to look at this line. If you can't see, you go to the tangential kind of this line. Then you will see the pulse is moving there. Right? So this, whether it's a JVP or not, what you can do is that two ways you can do. Either you press it, if the JVP, it will collapse. If it doesn't collapse, then it will be transmitted from the carotid. So another way you can do is, if you can see the wave there, you can push at the right subcostal region to push so that the inferior vena cava blood return will be increased. So that if increased, you will see the transient distensions of the vein. Okay, then you do look at the, you see, again, it's enhanced a bit and to go down very fast. So if you know this level, the JVP, you see the pulse there. You measure from the sternal angle. So this is perpendicular from the sternal angle, the ruler, one ruler, and the tip of this one perpendicular to it and reach the tip of this one, so that and read this how many centimeter above the sternal angle. read this, not this one. Huh? Okay, ruler from. So you read this one, maybe 2. He might have a 2 or 3 centimeter, 2.5 kind of. So it's normal, right? So this is a GVP identifications. You look at that, and then you come to the precordial examinations. Again, you look at whether it's the scars or whether it's an apical scar, whether it's a side scars or anything. Right? You just look at the medial sternotomy scar, any deformity, right? Then you go for the palpation. So palpation is first is there are 4 moves in the palpations. Apex beat. So testing for the parasternal heat and testing for the trail, optimal trail in 4 body area. That's about it. So when you test, you examine the apex beats, you have to push the hand down or outwards there, because when the apex displays, it will go downwards and upwards. So from here you press, you come back to your the fifth intercostal space kind of thing, and you come up like that. So that when you get the apex beat here, you feel it, point with one finger and count the intercostal, the second, third, fourth, fifth. So the examiner from the far know that you already get the apex beat is not displaced. It is in the fifth intercostal space. You already, even if you didn't present, you already know that you're pointing the apex beat. Then you go for parasternal heat. There's only left parasternal. There's no right parasternal heat. Right? Just the left parasternal heat. You just look at that, and then if you test for because once you already put the hand in, you already know that there's trail or not. You don't need to repeat that again. So it's just tricuspid valve, pulmonary valve, and aortic valve. That's finished with my kind of palpations. And then the auscultation will come. When you auscultate, the best way to do is that you auscultate all 4 areas with bell and diaphragm. So, okay. This kind of stethoscope, you see, there's no bell. There's no bell here. Because this is not bell, this is still diaphragm, this is also diaphragm. So, but this kind of stethoscope, they modify in a way that if you lightly touch the chest, it is a bell effect. If you press it, you have a diaphragm effect.
Eh?
So this is for bigger area, this is for smaller area. Right?
But doctor, you can twist it, right? This one.
Okay.
Oh,
But you know, this is for
Yeah.
smaller area, this is for bigger area. It's not a diaphragm and bell. See, I show you my bell, truly bell and truly diaphragm.
Oh.
So if you have this kind, this is a bell after all. You can see this is a bell. This is a diaphragm. So I don't have your kind of thing. So but if you're using your one, if you're using this kind of thing, you have to show that you turn to the bell and you listen to the bell lah. But here, if you want to show off, you can still use that one. But you need to lightly touch lah. Lightly touch. You don't press it. If you press it, it becomes diaphragm. All right. So these are the stethoscope tips. Okay. Let's poke a hole. Okay, come. So for auscultations, when you auscultate, the important thing is you have to feel the carotid pulse all the time. Right, so you feel the pulse, press on the left side. Okay. Mitral area, tricuspid, pulmonary, aortic. The sternal angle, right, at the side, each side. Then you turn to the bell. Okay. That's about the auscultation. You listen with all bell and all diaphragm. But it finished. So you have to do 2 maneuvers. One is, the extra auscultation is 2. Extra maneuver is 2. So extra auscultation is if you hear the pansystolic murmur here, you will listen to the axilla. If you get the aortic area, you listen to the neck. Okay, this is the 2 extra auscultation. And 2 maneuver is if you have a diastolic murmur, you suspect mitral stenosis. What you do is you ask the patient to turn to the left side, and during expiration, inspiration and expiration, during expirations, you auscultate the murmur accentuate. Can you turn to the left side? Okay, it's okay. Breathe in, breathe out, hold for a while. Okay, then breathe normal. Another one is you accentuate for the aortic regurgitations to accentuate. This is for mitral stenosis accentuation. This is for aortic regurgitation also. Can you sit forward? So when you sit forward, you have to auscultate at the herbs area, the third intercostal space, to the left sternal edge. And you listen here. Breathe in, breathe out, hold there. Okay. This, and then after that, you straight away listen to the base of the
lungs.
And breathe in, breathe in, and straight away check for the sacral. Right?
Okay.
That's one. Then lie back. So that only then I will check for the teeth now. So look for the video edema. If you have time, then I will just tell the examiner I would like to check the peripheral pulses of the lower limbs.